Welcome, everyone, to the last part of our specialty contact lens series. This is a topic that has been highly requested from many of you because there's been a lot of lectures that we've had about scleral lenses, but really not a lot about what happens if scleral lenses don't work. So this is an incredible and very, very exciting program that we have planned for you this evening. My name is Dr. Stephanie Wu, and I am the host of Wu University and the founder of Wu University. And it's now my pleasure to introduce today's speaker. Dr. Tiffany Andrzejewski grew up in Indiana and graduated with honors and a degree in biology from the Indiana University in Bloomington, Indiana. After that, she moved to Chicago, where she studied optometry at the Illinois College of Optometry. Following graduation, she completed a postdoctoral residency in cornea and contact lens management at Indiana University. And she is a true expert when it comes to all sorts of irregular corneas and anterior segment conditions. In addition to caring for her patients, Dr. Andrzejewski also lectures on various contact lens topics, and she serves as an adjunct assistant professor of optometry of the Illinois College of Optometry. She's also a member of the American Optometric Association and the Cornea and Contact Lens section. She is a fellow of the Scleral Lens Education Society and a fellow of the American Academy of Optometry. Welcome, Dr. Andrzejewski.
Thank you so much for having me, Dr. Wu. I really appreciate it and enjoy this opportunity to share some of my knowledge with our guest out there. Here are my financial disclosures. And so, as Dr. Wu mentioned, tonight we're going to talk about what happens when scleral lenses don't work. So I think the biggest obstacle we have when we're starting to fit irregular cornea patients is, where do we start? We have so many different options to choose from, but how do we know which design is right for a particular patient? How do we piece together the puzzle of lens design, material, power, modality, and how can we optimize these choices for each individual patient, given that we have all these many options? Let's dive a little bit deeper talking about those various options and when we might choose one over the other. So starting with soft contact lenses, we know that when a patient has an irregular cornea, that doesn't have to guarantee that they only get gas permeable lenses. If they have a mild irregularity or the topography is somewhat symmetrical centrally, kind of like the topography you see here on the slide, say their spectacle vision is pretty acceptable, maybe they're correctable to 20/20, 20/25, even 20/30, but they're not bothered by that. And they find that whatever acuity that they have, whether it's glasses or unaided acuity, is pretty satisfactory to allow them to perform their daily functions, and they're just needing a little bit better. That's when soft lenses can definitely work. So we use them when there's minimal optical distortion and adequate vision, potentially in glasses or with a refraction. But we have to keep in mind we need to achieve still an acceptable fit. We need that lens to sit nicely on the eye and not fluting and popping off. That's not going to give good success for the patient comfort or vision. And so we have several options. We have the off-the-shelf, as I call them, disposable options from our commercial carriers. We have extended range soft lens options, thanks to some of our companies extending those parameters. We have custom made options, as well as conventional replacement custom soft lenses for the irregular corneas. And when it comes to those specialty soft lens options that are designed specifically to correct the irregular or keratoconic cornea, they kind of fit into two classes. One is the design is designed to have an increased center thickness to mask the corneal irregularity and improve vision. And some other designs are a little bit thinner, but they incorporate aspheric optics to limit aberrations. So usually they're going to fall into one of these two camps to work for these patients. So when you might consider them again is when there's, mild irregularity. Another good candidate for these type of lenses are patients that are really hesitant about trying gas permeable lenses. Maybe this is their first way that they're tiptoeing the water into contact lenses. When it comes to fitting pearls for specialty soft lenses, no matter what you're fitting, you want to keep in mind and use the highest decay possible to help oxygen. You always want to pay careful attention to the refraction and especially to the cylinder axis and amount, because many of these patients have high cylinder correction, and really honing that in and refining that can give them the best vision. And then you want to set proper patient expectations. We know that, when it comes to soft lenses on our regular corneas, that sometimes to really optimize the vision, a gas permeable type lens may be better. But some patients are willing to sacrifice, say, a couple letters or a line of acuity for different reasons, depending on, several factors that we'll talk about, whether it's handling or comfort or cost or things like that. So when it comes to advantages, I think we know all of the advantages as practitioners of soft contact lenses. Some of the disadvantages for irregular corneas or those patients with high astigmatic correction is that the vision can sometimes be unstable. That lens can fluctuate and when they blink due to the toric rotation. Sometimes the replacement schedule of these more custom lenses is not a daily disposable. It's not even a monthly disposable. It might actually be quarterly. So there's a little bit of a care and maintenance regimen required for these patients to be successful. And then sometimes some of the mixed reviews can be cost. Sometimes, depending on the design, these lenses can be pretty costly to us practitioners and to the patient. They can take time to fit, and handling with a soft lens for some patients that have done soft lenses before, that's one thing, but for the new wearer, a soft lens is pretty flimsy and can flip inside out, and so sometimes handling a soft lens isn't as easy as one might think. Another option that we know, the tried and true, kind of our old standard of care option, are corneal GPs. We know they have great oxygen permeability, they're durable, they have superior optics when it comes to the irregular cornea or those patients even with normal corneas that need better vision, sharper optics. They're relatively quick and inexpensive to manufacture, and because of their smaller diameter, they can be, for some patients, easier to handle just because of geometry. Of course, we know some of the downsides of them, that they do take longer for patients to adapt. Patients readily feel them in the beginning, and so we have to kind of counsel them on, there is going to be some awareness in the beginning period. There can be some instability on the eye depending on how severe the shape of that cornea is, so they may shift off. We know about, the issues with debris getting under the lens, if it's in a windy or dusty environment. And, ultimately, any of these specialty lenses can require follow-up, so we have to prep our patients for that. When, that may not work or be just right for a patient, we always have the fallback option of piggybacking. This may be easy to forget about, and I know a lot of practitioners kind of poo-poo this option because they're like, who in their right mind is going to want to wear two lenses? But for the right patient, this can be a game changer and really work. The advantage is that soft lens is going to cushion and protect the cornea from not only mechanical rubbing, but also from the feeling of the GP. And that can also eliminate debris underneath the lens. I have many patients that wear gas permeable lenses, but when they go on vacation or they're out playing baseball or things like that, sports where they're in a dusty environment, they just like throwing the soft lens underneath, but they don't like the complexity of that maybe every day. We can use that soft lens to help with the stabilization and the centration of the GP on the cornea. And sometimes, if you have a working GP already and the patient says, I just need better comfort, I'm not getting all the wearing hours I need out of it, sometimes that allows us to enhance comfort without completely reinventing the wheel and causing these patients to have to buy new lenses. Obviously, there's some obvious disadvantages. Now they have to insert, remove, and care for two different lenses, so we have to worry about compliance. We have to pay attention to the decay of T over the system, and choosing a high, high, or oxygen permeable soft lens can definitely be key. We need to make sure that soft lens fits that cornea really well. Sometimes on our steeper corneas, more irregular corneas, it's hard to get commercial soft lenses to fit well. And when that fails, we always have the trusty hybrid contact lenses, which can, kind of enhance things one step further. A lot of our newer generation hybrids are going to vault the cornea apex centrally. They have a hyperbond junction, so it's not actually easy to tear that soft skirt away from the GP. The newer generation designs have UV blockers in them, and they also have high decay in the GP, high decay in the skirt, so we don't have to worry so much about oxygen and neurovascularization like we did in some of the earlier designs. And then we also have ways of promoting comfort with them with HydroPeg coatings. So number of advantages, mostly with that soft skirt, helping center that GP, that can sometimes actually give patients superior optics. There have actually been some studies that have shown that patients who have worn a hybrid lens can sometimes achieve one line of better vision than wearing a corneal GP. And that's purely because of the great centration that soft skirt helps provide. And there's also less movement. And so that improves the stability and comfort, less adaptation time for the patient. Because, as I mentioned, these newer generation lenses vault the cornea, we've got less issues with mechanical rubbing of a GP on the cornea. That soft skirt provides so much stability that the lens is not going to physically pop out. They actually have to pinch the skirt to remove it. So now we're actually getting that convenience of one lens versus two, unlike piggybacking. And then, it does have more rapid tear exchange than sclerals, believe it or not. And because they're fit with lower vaults, sometimes that can solve some patient problems, whether it's the fit or vision, which we'll talk about with some cases in a little bit. I think we know, if you know what a hybrid lens is, I guess you can imagine, the handling can be a little bit more cumbersome than a corneal GP or even a regular soft lens, because especially the newer generation designs, they are filled with an insertion saline, much like a scleral, and they're put on like a scleral looking down towards the toes. Cost, is up there. These are not an inexpensive lens for us, the practitioner, or for the patient. And there is a 6-month replacement schedule on these lenses. So there is a recurring cost with these lenses every single year for these patients, versus sometimes patients wearing a solely gas permeable lens or a scleral, sometimes they can get, more than a year out of their lenses. That doesn't really happen with hybrids. Sometimes the hybrid fitting is viewed as being more complex. That's just the initial chair time. But once you kind of understand how to fit hybrid lenses, I find that, they can definitely be very beneficial in my practice. And, there is, some customization definitely available, but we are kind of locked in that they do come in set diameters. They do come in, set vaults over the cornea. And sometimes there's only so much we can do when it comes to highly asymmetric or irregular corneas. And then, of course, we are not, surprised that sclerals are all the rage. We love them. They have great comfort, great optics. We can customize them a million different ways these days. And no matter how advanced that cornea is or how irregular, we can vault it no matter what. That's not necessarily the difficult part. Where it gets a little difficult is us as practitioners achieving that optimal fit, which can sometimes require multiple office visits. Larger lenses, we know, sometimes require more toricity in the haptics to get that lens to sit right on the eye. We know that scleral lenses tend to decenter inferiorly due to our EOM insertions, and so that can sometimes skew visual performance. And then there's always the dreaded lens fogging, whether that's the surface, the tear reservoir underneath, or corneal edema and health issues with the cornea. And then there's, some physiological concerns that, we don't actually have all the answers, and there's studies ongoing about, how does the decrease in oxygen supply affect our cornea, and do scleral lenses increase IOP? So there's, some level 2 sclerals that are definitely complex. When it comes to sclerals, we have diagnostic fitting, but we also have scan and impression-based sclerals to kind of utilize elevation-specific technology to help and do better for our patients. So there's a lot of advances in this area that allow us to help our patients, whether we're having difficulty aligning the landing zone to conjunctival irregularities of the eye, whether it's pterygiums, pinguiculas, glaucoma blebs, or drainage tubes. We have a really atypical corneal profile where average lenses, corneal GPs, hybrids, they're not going to stay or fit well in the eye. Or for those patients where we need really precise control of optics and prism and multifocals, and we just want to run the gamut of being able to really customize this lens, scan-based and impression-based lenses allow us to do that when it comes to sclerals. Of course, we're not a stranger to the advantages. Of course, there are some disadvantages. Again, cost. Sometimes we need special equipment. This is not available in all practices. This is kind of cutting edge and does take, an investment on behalf of the practitioner. But it does allow us for some really unique shaped lenses for some really unique shaped eyes. And so, given that we have all of these options, there's quite a few considerations we need to consider when we're choosing a particular design for a patient. So what I find is appropriate is we really need to dig into the patient's story and get a sense of what their disease state is. We need to consider their current level of vision, their visual needs, their current limitations. We need to consider how much oxygen their eye may require, as that can affect our lens choice. And we also need to consider the geometry of their eye and sclera in some cases, and what their physiological response to these lenses may be. So how do we determine where we go from here? So it's all about asking the right questions in that initial meeting of the patient. We need to keep those questions kind of focused and maybe start open-ended and move to more closed-ended questions. And following up about their history, we need to get to know our patients. What conditions do they have? What surgeries or injuries have they gone through? What are their visual symptoms? How are they feeling? What difficulties is their vision providing them? And, what can we potentially do? So once we know the problems, then we can kind of start devising a plan of how we can help the patient. And sometimes this turns into an emotional conversation. We need to know what their prior contact lens history is and whether they've used any types of lenses and what their experience with those lenses have been, whether it's the good, the bad, or the ugly, and where have things kind of fallen apart. Sometimes that allows us to better re-instruct the patient, or sometimes that allows us to kind of help the patient and choose a better option. And then it comes down to occupations and hobbies. So we need to know, how do these patients work and play? And how is the lens going to impact their lifestyle and allow them to do what they need to do better? Do we need to consider protective eyewear? Do we need to consider multiple lens modalities based on their needs in different environments? And then what are their physical limitations? Handling of contact lenses is not easy. If it was, everybody might be wearing them. Who doesn't like spectacle independence? But let's face it, not everybody is adept at touching their eye or putting in eye drops, and lenses aren't necessarily for everybody, even if they may need it visually. So we need to decide, what is their motivation? Why are they here, and what is it that they're hoping to achieve? And then that brings us to our examination. So we know, when fitting the irregular cornea, there are several baseline exam elements that we need to consider, some of which are going to be, what is their entering acuity, whether that's uncorrected, with glasses, with previous contact lenses. We need to know, what are they refractable to? What is their potential improvement that is able, whether that's doing a pinhole test or starting with a spectacle refraction to figure out what their capabilities are, so we can better have that discussion about what we think is possible. It's also looking at eye alignment. This may be something that goes unmissed, but many of these patients have very asymmetrical vision, and that may cause them to maybe suppress an eye. And so once we turn on the lights to that eye and get them better vision, sometimes we end up having difficulty with double vision or fusion problems or headaches or eye strain. And so we need to take that into consideration. And then on top of that, obviously perform a very careful anterior segment evaluation. That goes without saying. Some things that we're going to want to consider is HVID, as well as what is their VVID, or vertical visual iris diameter. Not all corneas are perfectly round. There are studies out on scleral shape and corneal shape that indicate that our HVID is actually wider than our vertical visual iris diameter. And so not all lenses will fit well if we have a big asymmetry. What's the patient's fissure width? If they have really small, tight eyes, are we going to be able to get in a big lens, or do we need to, kind of reevaluate things? What's their pupil size? What's their corneal status? Getting baseline photos and imaging so that we can monitor their disease. What's their lens status? Does this patient have cataracts? Do we need to have a discussion about how vision may change over time, or what their limitations might be to their vision due to cataracts, or, Also considering their eye shape and conjunctival abnormalities, lid abnormalities. This is a piece of plastic on the eye, and I always tell my patients, this is basically a new windshield. So we need to also address dry eye issues, tear film, MGD, do they blink fully? All of that is going to play a role into how this piece of plastic functions on the eye. And we also need to consider a posterior segment evaluation, because there can be other limitations other than what's going on in the cornea, and that may play a role with how much better we can make their vision. And we have to have those upright discussions with the patient about what they can expect. And then sometimes getting that diagnostic testing can really help us hone in further, whether that's a specular microscopy, topography, scleral topographies, profilometry, as well as aberrometry, anterior segment OCTs, pachymetry. All of that helps us put all together these puzzles. And so ultimately, the first step that I usually do after doing that entrance exam and refraction and looking at vision and all of that is getting a tomographical map. Not so much a topography, but a tomography is kind of my preference as far as way to go to figure out the corneal shape. Because what's different is tomography is not as imperative on the tear film. That doesn't play as big of a factor in us getting a successful image. And because it uses shine flow technology, it provides us also pachymetry information, which can be important to follow a disease, as well as posterior corneal surface data. Particularly these elevation maps can be really important to let us know what we might be able to fit on these patients. A study done has shown that patients with 350 microns or less of corneal elevation difference along their gradius meridian of change have an 88.2% chance of being successful with a corneal GP. That's important to know. So we have this big asymmetry between the inferior and superior corneas. We may find that corneal GPs or maybe even hybrids may not work for these patients. And that's where, we may want to consider a scleral. So what does that mean clinically? This is kind of a brief exercise or example to kind of show you that if we look at, this is a Medmont elevation map, if we look at the elevation difference between the flattest point of the cornea and the steepest point of the cornea, we find that there's a 655 micron difference. So you can see on the left, if we tried to do a corneal GP, we'd either get bearing superiorly and bubbles inferiorly or vice versa. We wouldn't really be able to, with a smaller diameter lens, deal with that asymmetrical difference. And that's where scleral may be more beneficial. And so sometimes having this information lets us know what other options do we have besides scleral lenses. We also have to keep in mind and watch that posterior elevation. We know with keratoconic corneas that the posterior part of the cornea kind of bows forward, as you can see here. And so many of our lens options will correct the anterior irregularities of the cornea, but not so much the posterior irregularities. And so even though we have the best fit lens, sometimes they still may have reduced visual acuity, aberrations, and other issues that we just can't fully address, sometimes even with the best fitting scleral lens. And all this comes down to looking at all of this basic entering diagnostic testing to determine what is that patient's corneal shape so that we can better fit a lens to that eye. Sometimes corneas are prolate, as you see superiorly, or sometimes they can be oblate, where you have that central flattening. And then I like to also use anterior segment OCT because I find that that's great for documenting and visualizing anterior pathology and can also help us better understand that shape. And so what that brings us to is, why don't sclerals always work? We know that they're great, but they may not be for everybody. And we're going to talk about, various complications, various contraindications, why a scleral lens may not be the right choice for a patient. Ultimately, studies have shown that the main reasons why scleral lenses are discontinued by our patients is first and foremost handling. That's about 35%. And secondarily is discomfort. And well, let's face it, for practitioners, there's intricacies in fitting scleral lenses, which can be a challenge. And there's a definite learning curve. There's been a study that looked at the learning curve of fitting a scleral lens, and they found that it takes 61 to 80 eyes before a new practitioner feels confident in their ability to fit a scleral lens. And then we start to see a decrease in the number of diagnostic lenses put on the eye, as well as a decrease in the number of lenses that are reordered to optimize that fit. And so there really isn't a one size fits all approach for, our patients. And we need to respect that and understand, although scleral lenses are great, that may not be the end all be all for our patients, depending on a number of factors. And so what are those factors that we look at as far as scleral lens complications? And what that comes down to is it could be user error, fitting issues, vision issues, and health issues. That's kind of how I've divided things up to talk about where we go from here in addressing, problems with scleral lenses. So starting with user error, we have the dreaded application bubbles. Here we have a patient that has a perfectly well-fitting scleral lens. He's got a really advanced cornea. This makes sense. However, no matter what he does, he's got small fissures, tight lids. He just can't get that lens in. And so we have to sit back and look at what are those alternative options for this patient. Looking at his pentagram topographies, we see that the right eye is relatively normal. He was already wearing a soft lens. He refracted well with glasses, so that made perfect sense. The left eye doesn't refract well. He did see really great with his scleral lens, but handling was an issue. He wanted something simple and lower maintenance. He'd worn gas perms before, so he was somewhat familiar with those. And so ultimately, that's what we ended up finding worked really well for him, because he had a very small central nipple cone and he was very, very successful. He didn't need a scleral lens, and that made his life much simpler. And ultimately, his final acuity was maybe a couple letters different. So definitely a success with another option. When it comes to handling, we know that there's a learning curve for our patients. It can take patients 30 minutes, 60 minutes and beyond to learn how to put on a contact lens, especially a scleral lens. And so here's a patient that owns scleral lenses. He did great. They were comfortable, saw really well, but it took him way too long every morning to get them in. He just never mastered that aspect of his lenses. And so he gave up wearing them. He thought it was too complex. Even though he saw well, it just wasn't worth it all the extra time in the morning. Our patients have busy lifestyles. What was interesting with him is he came in to see me and he's like, I'll do a scleral, but can we make it smaller? He was wearing a 17 millimeter lens. Turns out his HVID was 12.5. There's no way with an advanced cornea like this that we're going to be able to get away with a really, really small scleral lens on such a big cornea. We've got to vault and land past the limbus. So his geometry of his eye kind of limited that. And he also failed in the past with corneal gas perm. So even though he has that central cone like our last patient, that was going to be a no-go for him. So what did we end up doing? He ended up doing really, really great in hybrid lenses. We still have that vaulting aspect of the cornea, as you can see from the OCTs, but it's a smaller lens. All hybrid lenses are a standard 14.5 millimeters. That's the same size as an average soft toric, so it was definitely less daunting for him. And even though, yes, his application process was the same as a scleral lens, with it being filled with preservative-free saline, because of the smaller size, he did perfectly fine. So what are some indications for fitting hybrid lenses? I find hybrid lenses work really, really well for patients who have a unilateral irregularity or a big asymmetry. One eye sees really well and the other eye, is much worse vision. Central irregularities, as we saw in the patient before, works very well. Patients who need improvement and they're a little bit timid to try a corneal gas perm, or they failed in a gas perm in the past due to centration issues, discomfort, popping out. Piggyback patients that want to try new options. Poor scleral candidates, as we saw, in our patient case here, where he had handling issues, and patients just dissatisfied with piggybacking as well. So when it comes to hybrid lenses for keratoconic eyes, what we do want to keep in mind is it's not going to really work exceptionally well for our more severe corneas. And so, kind of your slam dunks are going to be your mild to moderate keratoconic patients. And so again, in the year 2022, we have a high DK skirt, high DK GP, and it's very customizable. All of today's newer generation designs are fit with having reverse geometry, and that really helps enhance the rate of tear exchange with these lenses, and also helps limit them binding to the cornea when they're fit appropriately. And believe it or not, studies have actually shown that the tear exchange rate for a hybrid is twice that of a scleral. The typical tear exchange rate for a scleral is less than 1% a minute. So something to kind of keep in mind for these patients. Another complication sometimes comes down to lens care and handling, as well as lens care compliance. We know with scleral lenses, multiple solutions are needed. We need to really spell out those instructions for the patient, because if we don't, we can end up something like this. So this was a patient that came to see me. He was wearing impression-based scleral lenses. They fit absolutely beautifully, but his complaint was, I go to work and I look like I'm high all the time. My eyes are red, they're irritated, they feel super dry. Turns out he wasn't using the appropriate solutions. He was using Boston Sim Plus, a multi-purpose solution. He was not rinsing that off before he applied his lenses. And he was using a regular bottled saline that was not preservative free. Needless to say, that caused problems with his success. Once we addressed his compliance issues and narrowed that down, he ended up returning to wearing the exact same lenses and did beautifully, and turned out he actually loved wearing scleral lenses. And we did have to treat his dry eye, but something to kind of keep in mind when it comes to sclerals is, depending on the patient, they are complex not only with handling, but also with that very specific care regimen. And then that brings us to fitting issues. Here's a patient of mine, came in wearing sclerals, ultimately really happy the first hour of the day, but then everything turns foggy. This is the dreaded midday fogging. We've all heard it if we fit scleral lenses. And so the question is, what's going on here? This is where we're getting sequestered lipids, proteins, cell fragments from the epithelium, makeup, mixture of all of these components sucking underneath the lens. We can manage it by the fit. Sometimes we have to manage it by eyelid hygiene. There has been no indication that this midday fogging and debris under the lens is an indication of increased inflammation on the eye, although we do see it more with ocular surface disease or patients that do have underlying inflammation. It's not guaranteed that that is the only reason why this happens, but we know it's visually frustrating for our patients. We have heard it. Patients do not enjoy removing their lenses 1, 2, 3, 4+ times a day. So causes of it are multifactorial. There are a number of variables. Again, ocular surface disease, as well as fitting issues, and as well as there have been studies that show that it can be due to the corneal epithelial cell turnover underneath all that saline. And so how do we address this? We can reduce the central clearance. We can adjust the landing zone. So when we put fluorescein over that lens, we're not seeing any of that leaking underneath to limit tear exchange. We can also change the solution. In my clinical experience, sometimes using a more viscous preservative-free tear can help slow down that tear turnover. Sometimes using solutions that have ion-containing solutions that more adequately mimic the natural tear film and the physiological osmolarity of the tear film can also help with these sort of situations. Of course, we need to address eyelid health, allergies. I have some patients that, they have floppy eyelid syndrome, so they have to rinse their eyes out every morning because they just produce lots of mucus. And sometimes, well, let's face it, we just have to consider another option and refit them. So with that foggy patient I showed you, this is his cornea, nice central nipple cone, and he actually did wonderful with a hybrid lens. Why might he do well with a hybrid lens? Well, that soft part adjusted to his sclera quite well, so we didn't have to worry about asymmetry. There's tear flow underneath the lens and doesn't completely seal off, but with that, there's less tear flow and there's less of a tear reservoir. Hybrid lenses are fit closer to the cornea, so there's less issues with bubbles and also less issues with fogging because of that lower clearance. Obviously, there's still some cons. We know that sclerals are great for those more asymmetric eyes, but sometimes this can be an answer for some of our patients. Other issues we sometimes run into sclerals is epithelial bogging. You may have seen this if you fit scleral lenses. It does not seem to be a long-term effect, as we've seen clinically and in the literature. We still don't know the reasons exactly why this happens, but some of the hypotheses are loss of the glycocalyx layer of the cornea. This could be a sign of epithelial edema, or potentially just an osmotic imbalance from the cornea being submerged with all that saline. It gives us this waterlogged appearance. Because I don't know about you, but I have seen this start out with a first-time scleral lens wearer, but once we're 2-3 months into them wearing the lens, sometimes that does dissipate. So again, something that you will see. Does this necessarily keep us from fitting a scleral lens or really worry? Not really, but something to know that you might encounter. Bigger issues that we sometimes get are limbal staining or chemosis. And why does this happen? Typically, it's because we are not fitting the lens appropriately. We're getting significant compression, or we're not vaulting the limbus, and we're getting that limbal staining pattern as you see in the bottom 2 pictures. And so exclusively, a lot of this is caused by a fitting issue. So here's a patient that came into my clinic, was fit with scleral lenses elsewhere, loved them, saw great, but man, are her eyes always red. And even if you look at this enlarged central photo, you'll see that there's really no blanching here. She had no staining when that lens came off. She just got red. Why does this sometimes happen? Well, we're putting a piece of plastic on the conjunctiva. It's soft tissue. It responds. Some conjunctivas are spongier and squishier than others. So we can end up with compression, impingement, or hypertrophy. A lot of times, again, this is all due to a fitting issue. So what happened? What did we do to help this patient that had these exceptionally red eyes? Well, what was interesting is she'd also tried soft lenses and had the same issues of redness. She had tried commercial sclerals, had the same issue, but she had suction and soreness. We even tried then an impression-based scleral lens. And that's the pictures you saw here. Still, same issues. And so what ultimately ended up working was a good old trusty Corneal GP. It never touched her conjunctiva. She never got red. So for whatever reason, her conjunctiva just didn't do well with something touching it, even a soft lens. So sometimes we have to consider that for our patients. You would think that somebody wearing scleral lenses would never go back to a Corneal GP, but sometimes you'd be amazed depending on what the issue is. We also have issues with conjunctival prolapse. That's where the conjunctiva gets kind of sucked up underneath the lens. A lot of that is due to the negative pressure forces beneath the lens, which kind of pulls that soft, spongy tissue, especially if they're an older patient that has chalasis. And a lot of times that can be due to a depressed area at the edge of the cornea. Sometimes, we know at this point that this is not ideal, but there really haven't been any long-term studies that have shown that this definitely hinders the patient from wearing a scleral lens. Ultimately, patients don't usually feel that they have conjunctival prolapse, but we do have to be careful because that conjunctival tissue can adhere to the cornea, and that can lead to vascularization, scarring, limbal stem cell issues. So sometimes that can be a long-term health issue that we do have to address in our fitting. Other issues that sometimes patients go through are fitting issues. And so we know the dreaded poor wetability, and that's because gas permeable lenses are a hydrophobic material. Sometimes ocular surface disease complicates this. Sometimes the patients complicate it with their hand lotion, the types of soaps they're using, or females with their cosmetics, sometimes even dirty suction cups. And so sometimes we have to remedy this by using plasma treatments, hydropeg, treating MGD, switching materials, changing to alcohol-based cleaners, educating them about putting cosmetics on after the lenses, changing out their suction cups and applicators on a regular basis and keeping those clean. Sometimes applying conditioner on their inserters and removers can help avoid some of this. But other vision issues that we hear in our regular cornea patients are glare, halos, shadowing, doubling. It's that dreaded, I see better with my lenses, doc, but it's just not good enough. Here's a patient of mine who came in. He was fit with scleral lenses elsewhere. He said, hey, the left lens, I see great out of. Vision in my right eye, not so much. And my right eye is my better eye. My glasses are actually better than my scleral lenses in my right eye. Is my keratoconus getting worse? Why can I not see as well out of my right eye, which is supposed to be my good eye? turns out, as you can see here in kind of their eye trace, is that on the upper left image, is that we're correcting those corneal aberrations quite well, but we're having other distortion coming from coma and higher order aberrations. This was not present in his left eye. And so needless to say, here's his corneal topography, very, very mild keratoconus. In fact, he does refract to 20/20, but his best corrected vision with a scleral was 20/25 -2. It just wasn't good quality. So you might say, okay, that doesn't make sense to me. If you haven't been fitting scleral lenses long enough, I promise you will run into this. And what is going on is that we see, if you look at his topography here, we see in the bottom, looking at his aberrometry readings, this is his cornea without any lenses on, we see that he has a positive coma amount. But due to his posterior cornea or his lens in his eye, he has a negative coma issue here. And so ultimately, when we add the front surface aberrations to the posterior or lenticular aberrations, we're finding that he actually together, they cancel each other out and he doesn't have a lot of aberrations. However, if I go back, this is with the scleral lens on, you can see the scleral lens corrected the anterior aberrations, but it causes all those posterior aberrations to come shining through, much like lenticular astigmatism with corneal GPs. And so this is a patient that, we tried commercial soft lenses. Unfortunately, they didn't fit well. Then we tried a custom soft toric lens. He had a higher sil, didn't quite like the vision. It was too unstable, still not as sharp as his glasses. But he did very, very well with the specialty keratoconic soft lens, where there was this increased center thickness, as you can see here. And so by having that increased central thickness, it smoothed out the cornea and gave him more even vision and cut down the cylinder quite substantially. And so that's where we have to consider when we're fitting specialty lenses, gas permeable lenses, whether they be corneal or scleral. Sometimes patients will complain of doubling and shadowing. And how do we determine whether, what they're experiencing is residual astigmatism or higher order aberrations? And so a couple of things you want to keep in mind is that if, a scleral lens decenters, that can kind of have a prismatic effect due to the asymmetric fluid reservoir. So that can cause issues. We also have lens flexure, and we can decipher that by doing a topography over the lens. And if we're correcting all of the corneal astigmatism, it should be spherical. We shouldn't see a toric pattern like we do here. But you also have higher order aberrations from that internal aspect of the eye. And you want to kind of keep that in mind. So sometimes running aberrometry ahead of time can be really valuable. Other issues that we'll come up against, which we can't really control all that much, sometimes are the health issues. And so what are we watching out for when it comes to these diseased corneas or scleral lenses, kind of causing other complications with the health of the eye? Sometimes that comes down to corneal neovascularization. So sometimes eyes already have neovascularization, especially our RK eyes. It's not uncommon to see that they end up with vessels within the incisions, or cornea transplant eyes. Patients who are wearing lenses extremely long hours. So we need to really optimize the fit of our sclerals by using a high decay material, having a modest 150 to 200 micron bolt, and also having thin central clearance of the lens itself, and that can help optimize oxygen. We need to watch out for corneal staining. If there's focal staining, sometimes that can be an issue with lens touch, as you kind of see right through here. Sometimes it can be due to solution sensitivity. This patient was using Boston Simplex for filling. Sometimes it can be due to just the toxic swamp of metabolic debris under the lens. Air bubbles will cause, focal epithelial issues and staining. And sometimes we have to be careful and not be confused. It could be the state of the patient's disease as well. This is an interesting complication we don't see very often, but this patient was post-RK and they suffered what was called wound gape with their scleral lens, where we would see, the suction of the scleral lens and the waterlogged appearance of the cornea would cause this gape in their RK incisions. And so the cornea specialist was super worried that that would be an issue for not only the fact that when they took off their scleral lens, they didn't see well, they couldn't really function, but also potentially issues for neurovascularization into those incisions. Because it causes a biomechanical weakening of that stroma. So this patient actually did really well with a, custom soft lens for regular corneas. Other health issues we run into is GPC and ocular allergies. Scleral lens wearers are not immune to GPC. The mechanical irritation from an ill-fitting or flat-fitting haptic can exacerbate and cause papillary reactions and worsening of allergies. So sometimes when we're coming up across these patients, we need to warn them about, the appropriate expectations. They may be more susceptible to midday fogging. We have to make sure we can optimize that fit as best as possible so that we're limiting that mechanical irritation. We have to optimize that surface to lessen friction so that it doesn't exacerbate it. We need to really drone home with these patients about hygiene because a lot of buildup on the lenses can definitely exacerbate this. We need to limit preservatives whenever possible, both for filling and drops over the lens. And sometimes we just need to use our topical medications to keep these things under control. But again, something that we need to address. It can pop up in patients who've been wearing lenses, and it could be a reason why sometimes doctors think it's okay to refit patients into scleral lenses. Probably the worst complication that we'll see from scleral lenses is infectious keratitis. Now that is really, really low incidence in scleral lens wearers. So the question is that low because it doesn't really happen? Or it might just be low because there's really only approximately 70,000 people wearing scleral lenses versus 30 million wearing commercial soft lenses. That may play a factor in this, but we know that when it does happen, it could be disastrous for our patients. But it's likely the same risk factors are at play as with our soft lens wearers, poor hygiene, overnight wear, exposure to tap water. Typically in the studies where we have seen that there is infectious keratitis with scleral lenses, there have been about 11 studies or reviews that have been posted in the literature about this. Typically they have all had a couple things in common, and that's been that there's been a compromised ocular surface, either due to ocular surface disease or utilizing scleral lenses to help treat pre-existing epithelial defects, or they've been post-surgical cases, and these are patients who are on immunosuppressive therapy, whether it be oral or topical. Probably one of the biggest complications we may see from scleral lenses is corneal edema. Now, there is little evidence that clinically significant corneal edema is provoked by scleral lenses in healthy eyes. But we do know that corneal edema does happen by about 2%. Now that's pretty equivalent to what we experience normal patients in a closed eye situation. The difference is these scleral lenses are sometimes worn for 14, 16, 18 hours. And so we definitely have to use caution in our transplant patients. So this was a patient of mine that came in wearing a scleral lens. She wore them on both eyes, but her right eye, after an hour, got super, super hazy. She kept inserting, removing it, thinking it was midday fogging. Turns out it absolutely wasn't. You can see the bullae of her epithelium coming up and touching the aspect of that lens, and that's all because of her cornea transplant. So ultimately, what did we do? She wasn't interested in doing a transplant right away or a partial transplant to help restore the translucent nature to that cornea. So we actually piggybacked her with a high decay soft lens, which helped comfort and prevent the bullae from rupturing. And she wore a gas permeable over that. And she did really, really well for a number of years until she was ready to, consider a cornea transplant again in that eye. So talking about scleral lens contraindications, ultimately, I'll be honest, there really isn't any absolute contraindication. However, there are some things that you just want to tread lightly on, and that's going to be these three topics here. When we're dealing with a patient with corneal endothelial compromise, whether they're a cornea transplant, a Fuchs dystrophy patient, anybody like that, our patients who have glaucoma, and are patients who may need to wear their lenses overnight. For example, I have patients who are firefighters, who are ER doctors, and they have irregular corneas. They need to see better to do their job, but they know that they're going to be honest. Sometimes they have to sleep in their lenses. And so what it comes down to is maybe a scleral lens isn't right for them. Or for example, I have a firefighter that his schedule is 2 days on, 2 days off. So when he's on shift, he wears custom soft lenses. When he's off shift, he wears his sclerals. And so sometimes you have to revolve your lens options around your patient. So talking about endothelial compromise, it can be really important, especially on our cornea transplant patients, that we perform pachymetry as an early baseline to help monitor the health of these eyes and to monitor the health of their eyes with the scleral lenses. And so we know that a central corneal thickness of greater than 700 indicates these corneas are starting to decompensate, because the average is about 440, 450, or sorry, 540, 550. When it comes to changes in pachymetry readings, over time, when you're doing comparison using a tomography or using anterior segment OCT and using a kind of optical map, the key that we have something that we need to be worried about is seeing a 40 to 50 micron difference is what's considered significant, because there can be some variability day to day or measurements, or depending on how many hours, of course, the lens has been worn on the eye. But sometimes using these optical ways of measuring this can be much more accurate or help you be in tune to smaller changes, versus ultrasound pachymetry, where we're not always measuring the same point on the same cornea every single time. Another way to assess endothelial function is going to be specular microscopy. And that's where this instrument is going to tell us not only about the cell density, but the cell size or polymegathism, pleomorphism, the corneal thickness, and just the overall morphology, health, and clarity of these corneas that we're fitting. We know that the average cell count at birth is 3,500 to 6,000 cells per millimeter squared. Adults on average have about 2,500 cells per millimeter squared. And that's because as our corneas age, we lose about 100 to 500 cells per year. What we do know is that anything less than 800 cells per millimeter squared has the potential for developing corneal edema. Anything in the 300 to 500 range is kind of critical, and that's where that was kind of my patient that we showed you. Her graft had that bullae, and she actually had about 400 microns of cells per millimeter squared on her cell density, which indicated she really shouldn't have been wearing a scleral lens. So what are we looking at with specular microscopy? Well, as I mentioned, cell density, the higher that number, the better, but it's not only about that number, it's about how are the cells looking and functioning. And that's where we need to really look at the CV, or the coefficient of variation, because that's going to tell us, is there a wide variety in size? We know these cells should be hexagonal, and they should be tight and concise, like you see in the picture here. So once we see that that number gets higher than 0.4, that can indicate that that's abnormal and that they have polymegathism. Then we also look at the hex number, and that's the percentage of hexagonal cells, and those are the cells that are keeping their shape. So that's an indicative of pleomorphism. So anything higher than 50% is normal. So the lower that number, the more concerning, and the higher the CV, the more abnormal. You also want to look at the scan about the numbers of cells that were analyzed in the sample size. Of course, the higher cell numbers that were analyzed, the more accurate or statistically reliable this information is. And it does give you some estimate as far as corneal thickness. Now, once we end up with really irregular or endothelial dystrophies, that's not entirely reliable as far as that pachymetry measurement in my clinical experience, and also based off of what's found in the literature. And so all of this can be very important information to understand, what lens type we should go with to avoid putting on additional physiological stress on these sick corneas. So here is a patient, as you can see here, very similar cell densities between the two eyes. The right eye has keratoconus, the left eye has a cornea transplant. However, you can see the difference in how those cells are and how those cells are definitely going to perform depending on what lens we put on. And so this is how this information can be used when we're deciding what contact lens might be best for a patient. And so this is a patient that we ultimately had this discussion of, looking at all of this information and decided maybe a scleral lens would not be the perfect lens for this patient. And we looked at other options. So kind of the take-home points about specular microscopy is it allows you to know who's at greatest risk before you consider a scleral lens. It allows you to have that discussion about, okay, what's the risk and what's the benefit of this lens? It allows you to discuss, okay, we can do a scleral lens, but we may not be able to, your cornea may not be able to sustain a 16-hour day of wear. You might have to do 3 hours, hour off, another 3 hours, or only 6 hours of continuous wear. Sometimes we have to have that hard discussion of maybe it's time to reconsider a cornea transplant, or maybe it's time to consider an endothelial keratoplasty to help revive those endothelial cells so we can fit a scleral. I have many patients that I've referred back to my cornea specialist for just that. But it allows us to discuss these things up front and let patients know of complications and to let them know what to be on the lookout for and that you have things under control and that you're going to monitor this and that you're putting their health first, because you can't always tell at the slit lamp. Last, we're going to kind of finish up with glaucoma devices. Many of our patients have glaucoma. They have other factors and other diseases. And so when you're dealing with an irregular cornea patient that has these glaucoma filtration or drainage devices, we have to definitely tread lightly because we do not want that contact lens compressing, rubbing those blebs and things like that. That can cause blockage to tube shunts with scleral lenses. It can also cause, any contact lens can cause erosions over these devices, and that can cause a major problem for the patient's ocular health. And oftentimes we need to, if we're seeing an overhanging bleb, kind of like this patient, this isn't too bad, but I have seen ones that are definitely worse. Sometimes we need to consider surgical revision. The glaucoma specialist may not like that, but sometimes, we have to keep in mind what that lens is going to do and how that lens can affect their long-term health. Sometimes, a scleral lens might seem like a great option, but sometimes going smaller can definitely be better. A GP, can work really well depending on how asymmetrical these corneas are, and it definitely can lessen that risk, putting them, at risk of erosions over their tube shunts or potentially, irritating a bleb. So then it also comes down to, appreciating when it comes to scleral lenses, what we don't know. The question of, who should be putting scleral lenses on? Do we only do the irregular corneas because there's definitely this huge visual benefit for them where maybe other lenses are not so much in their best interest? Or do we also kind of put scleral lenses on our normal corneas that just have, very unique prescriptions and high astigmatism? Well, we can argue that there's this great unknown. We don't know right now the long-term effects on the epithelium or the endothelial health. There's been speculation and studies that have, postulated that scleral lens wear can cause an increase in IOP due to conjunctival compression. Now, that's not fully definitive at this point because there have been some conflicting studies, and the studies are with a smaller patient base, but it's something that we want to keep in mind that although scleral lenses are great, one, they don't work for everybody, and two, should we be putting a scleral lens on everybody? I would argue, based off of, the number of cases I showed you this evening, that maybe not, but it's choosing the right lens for the right patient and kind of keeping that whole perspective in mind when we're trying to help our patients see better.